As you've heard this morning, we believe that we have developed an innovative process to guide patients back to primary care for family practice sensitive healthcare issues and concerns. For the next 3 minutes, I'm going to build a business case, but I'm going to start by asking you to set aside a few facts. I'm going to ask you to set aside the fact that if I was seen in a Calgary ED and didn't have healthcare coverage, I'd be charged a fee of $236. Now contrast that to the cost if, as an uninsured patient, I walked into a GP office and was seen there. Following AMA guidelines, I'd be charged a fee of $60. So on a per visit basis, what I'm asking you to set aside is that we have a protocol and a process in place that reduce the cost of a healthcare visit from approximately $240 to $60. Again, this new solution is only 1/4 the cost of the alternate. Now, just to make this really clear, what I'm asking you to set aside, let's say very conservatively that we refer 3 patients per day, modest and in line with what's happening at the FMC, 7 days a week at the 4 adult acute care sites. This totals 4,380 visits per year. The costing difference, if I ballpark the math for you, is the difference between a little over $1 million and $260,000, a savings of approximately $750,000. But let's set that aside. Also, let's set aside that those visits and associated cost savings could conservatively quadruple. But again, let's set that aside. Now moving on, there's a few more things that I want to ask you to set aside. I'd like to ask you to set aside the fact that patients presenting to the ED are agreeable to the referral to the tune of about 80%. And data from patients who have went through the process find that they're satisfied with the experience. As well, set aside the fact that going through the process, patients have not experienced any adverse health outcomes based on over 1,500 referrals. So really, what I'm asking you to do here is to think about this, that what we have achieved here is that we've simultaneously maintained health outcomes of the population, provided a good patient experience, at the same time reduced the per capita cost. In the language of Don Berwick, founder of the Institute for Healthcare Improvement, I'm actually asking you to set aside that we've achieved the triple aim. You may ask, why have I asked you to set aside all of these things? Well, the answer really is simple. It's the right thing to do for patient care, for continuity, and for access. Family practice sensitive conditions should be seen in primary care. Thank you.
Seems like an easy one to get going. Not asking for any money.
Hi, I'm a nurse, and if a patient is coming into the emergency department, once they've found parking, once they've sat down, once they've registered, I think getting them to move is going to be difficult unless you pay their parking. The other thing is, are you going to have an ambulance drive them, or are you going to ask them to drive themselves? What about the people who are dropped off? How are you going to look at who your sample is, and is that sample going to jump at the chance to go outside in January when they're sick?
So if I may, we've actually got answers to all of those questions, which makes me happy. So we have had 1,500 people accept the offer to refer to a family practice clinic away from the Foothills ED by a nurse. And all those people face those same challenges. So some of them were dropped off. In those cases, they sometimes choose not to go if they don't have a ride that can come and get them. People who have parked at Foothills, if any of you have ever parked at Foothills, you know that that's a challenge. But we're not finding that that is a barrier. People are accepting the fact that they've parked and paid for it, and the experience of going to the family practice clinic and in some cases facing parking challenges again is not the reason they say no.
We've got a question over here.
John Conley, have you thought about taking this, after hearing Max Velikat this morning, to a user app that would be interactive so that you could actually move that triage step one step upstream to be able to allow them to be diverted as opposed to actually parking and doing all the other things that we've just heard about?
Yeah, thanks. That question had come up a number of times in our discussion at the poster presentation session, and we think that it's a really interesting idea. We haven't got there yet, really. I think that it's something potentially for us to kind of consider in the future, but it's a really interesting idea.
We do know, just on that, so around the app, it's not an app, but we do have HealthLink Alberta already in place that is fielding about 16,000 calls a month right now, and about 10% of those are referred to Emerge. The other 90% are actually advised to treat their health issue in a different way. So we kind of have an app, but it's a telephone app at the moment, and we just need to think about how that would go in a different type of app.
So AHS does have a waitlist app that's already designed and fully deployed in the App Store. You might piggyback off that.
Just a quick one for you. Have you guys thought about how you're going to roll this out across the country? Like, what's the strategy for getting this into many hospitals instead of one?
Well, I think one of the things that we're learning is that we really have to do this in a measured way. That there's not, so as we've been talking with the 4 adult acute care sites, that it's been important that one of the keys to this is developing a strong relationship between the primary care clinic and the ED. So it's not something that we can just kind of post the process online and sort of say, have you know, try it out. It's something that is so I think that it's a measured rollout, but it's one that certainly can be under the right circumstances.
Thanks, Jeff. Sorry, I got to cut you off there. I'm
Okay.
going to be the hook today, guys. All right, off the stage. Thanks so much, everybody. Competitor
Thank
number
you
2.
very much.